Hello, and welcome to the symplr Education Series webinars. Today's webinar is titled Documenting Provider Competency with Kathy Matzka. Next slide, please. Next slide, Ms. Kathy. Yep. Today's webinar is brought to you by symplr. I would love to introduce Ms. Kathy. She is one of our guest speakers for our webinars. We are doing quite a few with her this year. If you did want to participate in the Joint Commission Credentialing and Privileging Standards webinar, we will be having that one on May 3rd. A couple of housekeeping notes. There is a handout that you can download in the right panel of your screen today that Kathy will reference at the end or in the middle of her presentation. Also, this is a NAM certified webinar. You will have your certification certificate sent to you this week. Please make sure that you add communications@symplr.com to your address book. You will also be able to view today's recording and download the slides from this presentation at symplr.com soon, and you will be receiving a second separate email with that information. And I would love to turn it over to Ms. Kathy now.
All right, thank you, Callie. All right, so what we're going to do today is we're going to briefly just talk a little bit about what is competence, and we're going to cover some regulations and accreditation standards regarding documenting competency and what has to be done in order to show that someone's competent. And then we're going to talk about some ways of monitoring competency using quality assessment, performance improvement, and focus on ongoing professional practice evaluation and even proctoring. We're going to talk about developing quality indicators and the way that we can document these recommendations. I want to apologize in advance if I have to mute myself. I have been just recovering from a pretty bad bout of the flu, so every now and then I have a cough left in me. So if you hear me mute myself for a second, that's what's going on. So without further ado, let's dive into this. So what is competence? Well, it's the ability to do a particular activity to a prescribed standard or a desirable outcome. And we base competency on evaluation of certain things. It's a person's knowledge, traits, skills, and abilities. And these are, if you're working in HR background, you're familiar with the KSAs, knowledge, skills, and abilities. But there's also traits that also predispose someone to be better at some things than other things. So when we're looking at physicians, the Accreditation Council for Graduate Medical Education and the American Board of Medical Specialties got together some years back, and they defined what they call core competencies. And these core competencies are things that physicians are going to be using to grade themselves. And the Accreditation Council for Graduate Medical Education has required that all of the approved medical schools and residency programs actually structure their curriculum around these core competencies. And the board certifications are also structured around these competencies. So these are things that physicians are well familiar with now. They've been around for a while. So looking at different things, that a person's medical knowledge, their patient care and procedural skills, their systems-based practice, how they work into, with the whole system. Medicine is no longer just one single event happening in one place. It's across a continuum of healthcare now. How someone's professionalism is, and their practice-based learning and improvement. This is their continuing medical education and how they're seeking to improve themselves. And also interpersonal communication skills play a big role in how we determine whether or not someone is doing a good job. So why do we do this? Verification of credentials. Why are we documenting competency? Well, patient protection is the #1 reason. We want to be able to do the best that we can to make sure that the people who are providing care to our patients are competent and qualified to do those things. And there's also risk management issues such as negligent credentialing. If a provider injures a patient through an act of negligence and it's determined that the hospital did not appropriately credential that person, then the hospital can be found separately liable for negligently credentialing that practitioner. And then we also have accreditation and regulatory requirements. If we don't, document competency and follow those requirements that are in the regulations, then we're not going to be able to get our licensure. If we don't meet our requirements of Joint Commission or HVAP or DNV standards, we're not going to get our accreditation. So there are those requirements as well that have to be met. So let's take a look at the CMS regulations and interpretive guidelines, and we're going to cover ones for both hospital and critical access hospital. There's going to be times where the ones that I discuss pertain only to one or the other. So CAH means critical access hospital. So the Medicare conditions of participation require, when you're privileging someone, that the hospital and the critical access hospital take certain things into account as part of their criteria for privileging. And these are character, competence, judgment, experience, and training. So these are all things that have to be part of your criteria for privileging. And then they go on a little further and talk about what credentials need to be examined. So they require that you have evidence of current licensure, that you have references of competence. These are what we think about as our peer recommendations, that there's an actual request for privileges, and there's documented experience and evidence of training and education. When we look at all these things, the hardest thing for us to get usually is the documented experience. And that's because many hospitals do, just will send letters back and forth saying, this is the date that somebody came on and there's no disciplinary actions and so forth. But it's a lot harder to get that substantive documentation about how many procedures did someone do and did they do them well. So let's look at a little bit about some letters that you have in your packet. There's, like Callie mentioned, there's a resource that you could download that has various documents and form letters and so forth. And one of them is a sample letter for verification of training. And this letter was put together by the ACGME and the American Hospital Association. There was representatives from NAMS and the Organization of Program Directors Associations got together and they collaborated to create this standardized form. It's a verification of graduate medical education training. So this group put together this letter, and the first section of it is the letter to send that the Graduate Medical Education Center, the program director is going to be sending to the hospital. So it's going to just be a form letter that you see similar to what you see on the screen here, just saying that they've, that they did finish the program during this date, that the form was completed either at the time the trainee left the program or was completed by the current program director based upon the review of that file. So when this thing first came out in 2016, they decided that at the time that the applicant completed, that the trainee completed the program, that this form would be completed one time, and that the form goes on for a couple more pages that has the assessment on it. And they would complete it one time and put it in the file. And then for people who completed their training before 2016, if and when that program receives a verification request, the current program director would review the file and complete the form based upon the information that's in that file. And then they would sign that form, send it to the requesting hospital, and then they put that form in that file. And then each time somebody would additionally request it, they would send the same form. So what you may find is that you may get a letter from a program director back, and it might have a date that, say, 2 years ago. But and keep in mind that information is static. It's not going to change. When they get out of that training program, the information is going to be the same as it is 3 years from now, because that static information that doesn't change. The next letter I want to call your attention to is the sample letter for facility privileges and competency validation. Now, we all send these letters back and forth to each other that says things, we'll send a letter to a hospital and it'll have a 3-page evaluation form and a copy of the privilege form, and what we get back is a 1-page letter that says, due to the volume of requests that we receive, we're replying with this form letter. And then we get the dates on staff and whether or not there was any disciplinary action. Well, those types of letters are fine for hospitals where someone's not currently working. But remember, when you look back at those CMS regs, they did say that we needed to have documented experience. So what we try to get, instead of just a form letter, is something more substantive. So we ask them to provide more information than that. We want to get a list of the specific procedures that they're doing, or get a copy of their privilege form, and any outcomes if they can provide that to us. So we ask them to provide that, and this is something that is difficult to get sometimes, and what you pretty much end up having to do is have a very hard and fast rule in your medical staff in your hospital that you're not going to let someone be on staff unless they have this information. Because this is really the only way that we can document competency, is by having something that shows that they are doing the procedures and that they are doing them well. Another letter that is included in here is this sample peer recommendation letter. And the reason that I wanted to bring this up is I've seen many of these, and they're usually very good. The one that you have in your documents is meets the Joint Commission standards, including the requirements that they have for peer recommendations. But I wanted to just call your attention to the language that says our policies require that you complete this form. We don't want to have them give us a handwritten or a typed letter. We want them to answer our questions that we have on our form, because if they're not doing that, there may be a question that they're trying to avoid. Okay, the Medicare conditions of participation go on a little bit and say that it can't be assumed that everybody can do every task activity privilege that is specified for that applicable category of practitioner, and that individual practitioner's ability to perform each task activity privilege must be individually assessed. So the critical access hospital standards are a little bit different, and they say that there has to be appraisal procedures that evaluate their training, education, experience, and demonstrated competence as established by the critical access hospital's QA program and credentialing process, and how the practitioner adheres to your policies and procedures, and also that they're practicing within the scope of their state laws and regulations. So Joint Commission hospitals have a little bit different language, although they do kind of include some of the same type of language. They're just a little bit different wording. The credentialing standard says that they have to include credentialing process has to include requirement for verification of relevant training, competence, and current licensure, and that these verifications need to be in writing and come from the primary source if possible, or a credentials verification organization. Under the privileging section, they say that there has to be criteria based on medical staff recommendations and approved by the governing body. Now, this privileging criteria has to include data from professional practice review from other organizations where the applicant currently has privileges, if that is available. So in order to get that data, we need to have the type of letter that we addressed earlier of, you have to fill out our form, and we want to have a copy of the privilege form and a listing of the procedures that they've done and any outcomes if you have those. So what we're doing is we're getting that information from them. You don't know if it's available unless you ask for it, right? So you have to, at least asking for it, you can say, yes, we did try to get that information, and sometimes, like I said, they will not provide that information to you from another hospital. But if that's the case, then you go back to the practitioner and have that practitioner intervene for you, and maybe have the hospital give it to them, and then they could then forward it to you. Also, the Joint Commission requires that when you're renewing applications, you're doing a re-credentialing, that there's a review of the applicant's performance within the hospital, and recommendations from peers and or faculty have to be part of that recommendations for privileging. Before recommending the privileges, the medical staff has to evaluate any relevant practitioner-specific data compared to aggregate data when that's available, and morbidity and mortality data when available. So it's another reason why we need to take a look at this stuff. Ask for it, because it is a requirement that from the Joint Commission that the medical staff evaluates these things when they're privileging. There's also under the privileging requirements for the Joint Commission, this requirement the hospital has to have a process to determine whether it has enough information in order to make its decision, and everybody who is requesting like privileges has to be evaluated consistently. So there can't be any playing any favorites or anything like that. So having adequate clinical performance information is, something that may be a moving target in some cases. Usually you need to have a department chairman, a clinician, a physician look at the information and say, is this enough information? And if it's not enough information, then we need to go and get the information from somewhere else. So for example, if you have a practitioner who has full privileges at your hospital, surgical privileges, and hasn't done any procedures at your hospital in 2 years, then the department chair might say, well, we have nothing to make our decision determining whether or not this person is qualified or competent. So we want to get information from another hospital where they're currently working to be able to evaluate that information so that we have the information we need in order to make a reasoned decision regarding this person's privileges. Okay, so let's talk a little bit about monitoring proctoring. So after you get your privileges, there's also a requirement that there's some monitoring and proctoring that goes on. Now, proctoring is not required. It is one way of doing monitoring. Many hospitals do have a policy for proctoring. Some only do that. Some do it on every practitioner. Some just do it on random people as the need arises. So, and when I say random, I mean if there is an incident that occurs that's not usually, an unusual incident, you may see that somebody has exceeded their benchmarks for surgical incidents or something like that, and you may have a proctor, or you may have a case where there's somebody who is who you don't have anybody else. It's a brand new procedure that just comes to your facility, and so you might have a vendor rep that comes in with a specialist to proctor. So provisional appointment is something that some hospitals do, not all do anymore. It used to be that every hospital had a provisional requirement, but that language has kind of gone away now, and we've kind of replaced it with our focus on ongoing professional practice evaluation. But I do see bylaws that still require provisional appointment, especially if you're not a Joint Commission accredited hospital and haven't adopted that focus on ongoing professional practice evaluation language. So during a provisional appointment, it may be for a year or 6 months or so forth. And during that time, the clinical work of that practitioner is reviewed and evaluated during that time. And it might include proctorship. It might include just doing a retrospective chart reviews. It may be reviews while people are in-house. Now that we have electronic health records, a person who is monitoring, someone can sign on to the electronic health record and actually monitor them through, their care of that patient through that record. We can also, do a number of different things, have a mentor set up with someone, or sometimes it's the department chair that's responsible for oversight. However you do it, whatever your medical staff decides is pretty much up to you to decide how to do it. So there also, you need to have adequate volume. You have to make sure that you have enough people that are providing enough volume to be able to evaluate someone. Sometimes we get someone on staff and they've been here for 6 months and they haven't done anything. They haven't admitted anyone, and so that provisional appointment might have to drag on and on and on before you can get them off of that provisional appointment. The quality assurance performance improvement is another way that we evaluate performance and competency. And the QAPI, the CMS, the Centers for Medicare and Medicaid Services, defines it as the merger of two complementary approaches to quality, which is our quality assurance and our performance improvement. And both of those involve seeking information and using it, but there are some differences in QA and PI. QA is where we're trying to meet quality standards, ensure that care is reaching an acceptable level. And we do this by setting quality assurance thresholds. We set standards that might go beyond regulations. We might say, well, the national standard is a 5% complication rate, but we're going to shoot for 3 or something like that. But it tends to be more of a reactive, retrospective effort, and we use it to examine why we didn't meet certain standards. Once we get our benchmarks and we find what happened, we evaluate them to try to figure out why something didn't meet the standards that we've established or the benchmarks we've established. QA activities do improve quality, but but typically the efforts will end once a standard is met. So for example, you might be evaluating a certain procedure, to determine whether or not people are being treated appropriately for, say, pneumonia. And once you evaluate it for a year, you might say, oh, well, everything's looking fine. We've reached an acceptable level. So we're going to just quit monitoring this specific diagnosis. With performance improvement, sometimes it's also referred to as quality improvement. It's more of a proactive and continuous study of processes. And the intent with PI is to either prevent or decrease the likelihood of problems occurring. And we do this by identifying areas of opportunity. We test new approaches to try to fix underlying causes of problems that are persisting. The aim of this is to improve processes, all the processes that are involved in the quality healthcare delivery. So PI can make a good quality assessment even better. So it can enhance that process. So just kind of giving you a little bit of a side-by-side example. Quality assessment or quality assurance is about inspection, and PI or QI is more about prevention. QA is more about measuring performance against predetermined standards and benchmarks, and PI or QI focuses on improving processes and reducing variations so performance increases for all staff. And with QA, the focus is on identifying outliers or maybe bad actors, the practitioner who's a problem practitioner, and improving that person's performance so that they meet the standards. With PI and QI, if problems are identified, attention is directed toward a process and not individuals. Now, of course, if you, during the course of a performance improvement, quality improvement effort, you identify that there is a single person who is an outlier or a bad actor, then of course you would focus on doing a focused review of that particular practitioner. Performance improvement, the Joint Commission itself has a certain definition of it, and they call it the continuous study and adaptation of a healthcare organization's functions and processes to increase the probability of achieving desired outcomes and better meet the needs of individuals and other users of services. So it's kind of the same type of language. They have some specific requirements in performance improvement. You need to monitor patient care. Certain things that we look at is appropriateness and timeliness of care, making sure that we have a mechanism for responding and reporting issues, addressing any kind of impediments to improving patient care. And of course, what we want to do is enhance patient outcomes. Joint Commission has the focused professional practice evaluation, and this is something that Joint Commission came up with, and really when they came up with it, people were kind of stressing out about it. And when I evaluated these standards, the new focused professional practice evaluation standards, I pretty much found that a lot of the standards that were included in the new FPPE and OPPE were there in some form or another in the current Joint Commission standards. They used to have a whole section on peer review. Well, that's all gone now. There's no section on peer review. A lot of those things have been migrated into the FPPE and OPPE. So what Joint Commission says is that there needs to be a period of focused evaluation for all initially requested privileges. So this means that if it's a brand new person who comes to your staff that wants privileges, a current medical staff member who is requesting new privileges, all those need to have a period of focused professional practice evaluation. Also, when an issue is identified and that issue is determined to affect the provision of care or provision of safe, high-quality patient care, then again, a focused professional practice evaluation is appropriate at that time. Joint Commission does require that this is consistently implemented, meaning that you can't, your process needs to be for all initially granted privileges regardless of who it is that's requesting those privileges. And then the ongoing professional practice evaluation is something that happens after, somebody is granted their privileges. So you use this in your decision to revise, revoke privileges. So this is something that, again, needs to be a clearly defined process. Everybody needs to be pulled into this. All the practitioners need to have a period of professional practice professional review as long as they have privileges. So if they are granted privileges, regardless of what those privileges are, they are subject to OPPE. The type of data that's collected with OPPE is determined by the individual departments. If you're a departmentalized medical staff, so that means that the Department of Medicine defines their indicators, the Department of Surgery defines their indicators, and then those are approved by the medical staff. And the information that is collected during OPPE is used to determine whether to continue or limit or revoke someone's privileges. Now, as people often ask me, well, you know, I'll hear people refer to, well, once they get off their FPPE, then we have to get them on OPPE. Well, that's not true. OPPE starts the minute the privileges start. Your ongoing monitoring starts right away. So you're looking at these indicators. You don't move them from FPPE to OPPE. It's not like a provisional staff appointment to an associate staff category or something like that. So OPPE starts as soon as the privileges are granted. FPPE is the time-limited that you give when somebody initially is granted those privileges. And the idea of FPPE is that we want to get this done, get them evaluated, and get that over with. But ongoing professional practice evaluation continues from the initial granted privileges all the way until the time the person leaves the facility. So when you're looking at Joint Commission standards, they have these mechanisms, these components of FPPE, including on what is the issue and when is the FPPE starting, how are we going to identify and document the issue, and what kind of periodic reporting do we need, and what kind of interventions need to be taken to review and correct any kind of problematic issues that occur. What's the start and the ending dates of the review, and we need a final analysis and a mechanism for reporting those results. Now, I have in your documents that there's a sample focused professional practice evaluation plan that's included in there, and there's also a policy and procedure. So this is the type of form that could be filled out for somebody, say there's somebody brand new starting on your staff. Your medical staff credentials committee or your department chair may look at this and say, all right, then, and to fill this form out. Initially requested privilege for a current medical staff member or a newly credentialed practitioner to the staff. You check off what's appropriate. When's it starting and ending? Is it volume specific? Is it time specific? Maybe it's both. Maybe you want a certain number of procedures within a certain time frame. And how are we going to do this monitoring? And this is where we really break it down. So the chart, is it going to be a chart review? If so, is it going to be retrospective or concurrent? And who is going to be doing that review? Is it going to be direct observation? If so, who's the observer? Are we going to be monitoring their diagnostic and treatment techniques and clinical practice patterns through our QAPI program? Is that what it's going to entail? So this can be customized to, depending on what the information is that you receive during your credentialing and privileging process. So for example, if you get a training letter from a training program director and somebody just comes out of their training, they come to you right out of the training program and you have a letter from the training program director and they say, he was trained to do everything that's on your, included on your privilege form. He did a great job. Here's a copy of attached is a copy of the log, procedure log for all the procedures he did at the program. We highly recommend him. You have that, and so you have clear documentation that this person was trained to do everything that they want to do at your facility and that they've been doing it well. So what your medical staff might look at it and say, okay, well, based upon that, we're going to do a retrospective chart review of the first 5 cases or something like that. But suppose you get somebody who you can't really get much data on. Say that you have somebody who is somebody who's been on your staff for a couple years, and maybe they're an OBGYN, but they really haven't delivered anybody at your hospital in 2 years. So what your medical staff might look at and say, okay, well, based upon that, what we're going to do is we're going to do a concurrent review, and we're going to evaluate the care of that patient as soon as they come into the hospital because we haven't seen anything from this person in 2 years. So that's how you can customize this to each practitioner. So the Joint Commission has some what they call potential aspects of OPPE and FPPE. So things that can be done is periodic chart reviews, direct observation and proctorship, monitoring of diagnostic and treatment techniques, and discussion with other people involved in the care of the patient. One thing that I might caution is if you're going to be using this section about documenting other individuals involved in the care of the patient, which is a really great thing to do. You can go to the OR, talk to someone in the OR, document, do they know their way around the operating room? Are they showing up on time? Do they seem like they're treating people correctly and getting along with people and so forth? If you're going to do something like that, make sure that you include that as part of your OPPE plan, and so that it's protected within the auspices of your peer review statute. And make sure that it's documented as such, that it is a peer review function that's occurring when this conversation is happening, so that you do have the protections of your peer review statute when you're doing those discussions. Also, proctoring. Proctoring is kind of out there for people to kind of to use if they want to. Some people don't use it. People have different rules for it. Some people's rules allow that you can have more than one proctor. Some people's rules say that they can be partners. Some people say they cannot. So it just depends on how your bylaws and how your proctoring policy is spelled out. I have seen hospitals that allow partners to be proctored. I've seen hospitals that didn't allow partners to be proctored. I remember speaking with the chief of surgery one time and asking him what he thought about partners as proctors, and his answer to me was that if I'm going to be proctoring a new person coming in with me, I'm going to be much more critical of them than I am than somebody who doesn't have the same feeling about them as I do, because it's what that person does is going to be reflective upon my group. So I'm probably going to be tougher on them than somebody else. So there's other rationale, people that say, oh, well, if you're a partner, you're going to probably not be as strict, but I guess it just depends on the person who's doing that proctoring. All proctors should complete a form and report findings via standardized process. And there are some sample forms that are included in your documents, different types of proctorship forms for different specialties, medical, surgical specialties, and some allied health professionals and so forth. So feel free to look at those at your convenience. So one more thing about developing indicators too I want to cover. There are some general indicators, and these are the types of things that we may include for everybody, what their core measure compliance, drug utilization, blood utilization, and so forth. These are the types of things that we look at for most practitioners that are on our staff. These are things we're looking at on an ongoing basis. And so these are things that can be indicators that we can look at for competency. We also have specialty indicators, and these are the types of things that we're talking about where the department selects what those indicators are going to be. So for example, general surgery, a focused professional practice evaluation for core privileges might be looking at a certain number of procedures for each surgical and filling out a surgical review form for each. It may be reviewing charts for adequacy of consultation and operative reports. And you may split it into different categories. You might say, we're going to look at one in head and neck, one alimentary tract, one in abdomen, one vascular. So you get a good rounded idea of different body systems and how that's working. With focused professional practice evaluation for general surgery, it might be outpatient surgery, patient gets admitted for complications, or an unplanned injury, removal, laceration of an organ, having a consultation delay of greater than 24 hours, or leaving a retained foreign body, or something like that. And for OPPE indicators, it may be the same type of thing. Unplanned return to surgery rate, the rate of compliance with surgical infection prevention measures, and complication rates. And so you're looking at, different indicators for each one. For medicine, it may be looking at charts and determining whether or not the history and physical is adequate, if the consultation reports are adequate, looking at certain diagnoses. For FPPE, you might look at anything that, like an unplanned transfer to a special care unit, adverse outcomes related to, a natural course of illness, critical abnormal lab results not addressed death, certain things like that, OPPE, pneumonia measures, CA VHF, looking at all these ongoing things that we're looking, these indicators that we look at on an ongoing basis. So these need to be defined by the department according to the Joint Commission. For advanced practice nurses and PAs, these can be a little bit more difficult. If they are in a medicine category or surgical category and they're doing the same types of things that a physician would do, of course the same type of things may apply to them. For example, for an emergency physician, an emergency department PA, you might have the emergency department physician monitor a proctor for a number of shifts and visually monitor them for certain types of procedures, maybe intubating a patient or whatever. For ongoing professional practice evaluation, you would look at the same types of things as you would for an emergency department physician. Patient dies in the emergency department or comes back to the ED within 48 hours for the same complaint, or getting admitted to a med surg unit and then getting transferred to ICU within 4 hours or so of admission. And like for the CRNA, focused professional practice evaluation might be the anesthesiologist might have to be present in that operating room for the first maybe 2 major surgical procedures, or if it's a maybe you're having, you have only CRNAs in your practice. You have no anesthesiologist. If that's the case, then you may have to have another CRNA who has full privileges that is there to proctor them for the first couple of procedures. And again, that issue of discussing with OR nurse manager, OR staff, how they're doing and so forth. For ongoing professional practice evaluation, again, you look at the same thing as you would for a physician. ICU admission due to anesthesia management. You might even look at things like medical records legibility. And again, there's some sample indicators and evaluation forms that are included in your packet. So when you're developing indicators, one thing to keep in mind is to try to keep it simple. Try to see what kind of data that you're already collecting. Sometimes you can find that there are data out there that you don't know in the medical staff office that's even being collected. I remember I was at a hospital that we were prepping for Joint Commission survey, and the medical services professional told me that she was concerned that she thought that the doctors that were working, that the cardiologists did not have specific indicators collected for them. And so I asked her, well, what's being collected in the cath lab? And she wasn't sure. So we were able to go get the indicators that they were collecting and reporting through the cath lab and use that as part of the OPPE. And so there are things that are occurring that you may not even know about within your facility. So see what kind of data is already being collected. And maybe there's something, that if there's something that can be obtained without a lot of difficulty, talk to your your QI professional and find out what kind of data is being collected that you can pull into these indicators and your evaluation of the practitioner. And don't select too many measures. I remember when the Joint Commission first came out with this, with the ongoing professional practice evaluation, and I went to a seminar that the Joint Commission gave, and they kept saying, keep it simple, that you don't try to select so many indicators. If you give your department chair or your QA committee meeting or your credentials committee or MEC a 3-page list of indicators for each practitioner, they're never going to be able to get through all of that. So keep it simple. Don't select so many measures and report out so much data that there's no way of evaluating it. You need to make sure there's enough to evaluate their performance, though, that you have some significant data to look at. And compare it to other providers that are within the same specialty that are treating patients with the same type of diagnosis. Make sure those indicators you pick are pertinent, that they relate to issues for your facility. And then ask doctors, what do you think we ought to collect? Ask your ENT doctors, what kind of performance indicators do you think are specific to your specialty? And do you have is there a specialty organization that you know of that has developed indicators that we can use for benchmarking? And then, of course, delineate all those indicators. Let everybody know what's being measured and how it's being measured. So when somebody new comes onto your staff, you send them a letter that says that, congratulations, you've been appointed to the medical staff. keep in mind that you're going to be subject to focused professional practice evaluation for the first, 5 records that we review, and your ongoing professional practice evaluation will be evaluated, and here are the indicators that we're collecting. So everybody knows what's being measured and how that's being measured. Another thing to consider is attributing care to the right person, which can be difficult now, especially since we have hospitalists that are doing a lot of care. So you may also have a big group of doctors who are rounding and they take turns. You might have a group of cardiologists that has 5 cardiologists on staff, and each one of them takes a day making rounds. You may have family medicine and internal medicine doctors that are serving as hospitalists, and there's a different hospitalist seeing the patient every day. So you have to determine how you're going to attribute and measure that care. So you have to determine, should that patient or service be associated with only a single physician or with a group of physicians? And some people even suggest carving a hospitalist out of the general internal medicine and just looking at them separately. There's different rationales on how that should be done. I've worked with hospitals who said that whoever does the H&P is the person we're going to attribute it to. I've seen the hospitals that say whoever does the discharge summary is a person we're going to attribute the care to. What it gets down to, though, is when there are outliers, you have to, of course, drill down and see, of course, looking at the specific case, where the particular issue was, and if it can be attributed to a single person or if it was the group as a whole that you need to attribute that to. There's a really good resource online. It's called Pay for Performance in Healthcare Methods and Approaches, and it really is more dealing with billing, but it has some really good ideas for carving out and separating, determining who you're attributing the care to. So that's a free resource that's available online if you're interested in that. Also, when you're documenting recommendations, we're doing all this work, we're collecting all this information, and we want to make sure that we have, everything we need to determine this person's competent. We get everybody to sign off on everything. Everything's reviewed. Well, we have to make sure that we are actually documenting that we've done all this work. So you can use standardized forms for OPPE and FPPE where the department chairman signs off on it. You can also use standardized forms for your appointment and privileges where you have your competency statements. But making sure that you have things documented appropriately, that you have your minutes for your quality meetings or whatever meeting you're reporting your FPPE and OPPE in, that you have it appropriately documented, that your medical staff has reviewed those indicators, that reviewed those profiles, and based upon the individual information that they've looked at, that they feel that this person is competent and qualified to continue their privileges. Then there's always the question of, where do you store this information? Does it go in a credentials file or does it go in a quality file? And it's really pretty much up to your organization. A peer review statute will protect that document regardless of where it is stored. So if you put it in a separate file that says quality assessment and performance improvement and peer review and stamp confidential all over it, or if you just put it in the credentials file, either way it's going to be protected by your peer review statute. The only qualifier I would have for that is if you have people who have access to your credentials files who don't need to know about things like the peer review, then you would want to keep those separate, because if it's somebody that doesn't need to know about that, then they probably shouldn't have the access to it. So if your credentials files are restricted to people who have access to both the quality data, the peer review data, and the credentials file, there's really no reason to keep that in a separate file. It's okay to do it that way, but your peer review statute is going to protect it regardless of where it's stored, and where you keep it is just a matter of geography. Okay, I want to just close with a couple surveys that have been recently, well, this one's not too recent, it's 2006. American College of Physician Executives did a study, a patient survey on trust and safety, and they asked the same questions to doctors that they did to patients. And there was hundreds of questions, but one of the questions was, is there a doctor in your community that you would avoid because you think he or she makes medical mistakes? So patient responses, 20% of patients said yes. 78 no, and 2% really didn't know. But look at the jump when you look at physician responses. 77% of physicians who were surveyed said that they knew of a doctor that in their community that they would avoid because they felt that he or she made medical mistakes. That's pretty significant. The Mungen Institute for Health Policy at Massachusetts General Hospital did a study in 2010. This was on whether or not people thought that they should report impaired colleagues. Well, 64% agreed that physicians should always report their impaired or incompetent colleagues, which is better than half. 17% of the people surveyed had direct personal knowledge of an impaired colleague, but out of those 17%, only 67% of them reported. And the reason that they gave for not reporting, they said someone else is taking care of the problem, or nothing's going to happen if I report, or maybe fear of retribution. Maybe they figure if they report someone, then they may not get referrals. Their referrals might dry up. They might get blackballed. They had a very sad ending on this survey results that said our findings cast serious doubt on the ability of medicine to self-regulate with regard to impaired or incompetent physicians. One more I want to go over too is that Medscape did an ethics report in 2016, which they reported at the end of last year. And these are a couple screenshots from some of those the reports, the survey results. One of the questions was, the survey was a medical ethics, a Medscape ethics report, and it was on money, romance, and patients. And one of the questions they ask is it ever acceptable to cover up or avoid revealing a mistake that would harm a patient? Now, there's over 7,500 physicians in 25 specialties that were in this. And out of these, 78% said, no, it's never acceptable. 6 years ago, though, 95% in the year 2000, 95% of physicians said it's never acceptable. So that's changed somewhat. So it dropped to 78% in the 2016 survey. Some of the comments that the doctors put in there, there's no pleading the Fifth Amendment in the hospital, only in the courtroom. What doctor wants to self-incriminate? I wouldn't lie if asked a direct question, but I might not volunteer that I made a mistake if I saw the potential for serious harm to the patient by doing so. One guy said, we all make mistakes, however, covering up for them is never acceptable, especially when a patient may be compromised. Now, many of those doctors who said it depends, 14% of them said it depends on whether or not they would cover up. They wanted to know more about the situation, how could it cause harm, or how good is my rapport with the family, or how much harm was done. So there were some other questions that they had that they needed more information for to answer that. Another one, would you report a colleague who occasionally seemed impaired by drugs, alcohol, or illness? There's really been very little change between the 2016 and the 2014 and 2012, little change over the years. Large majority of physicians said that they'd report an impaired colleague, noting the importance of patient safety. Many of them said that they would only report a colleague after individually approaching him or her first. And some even said they'd try to get them help, and others even said that they would warn them in advance that they planned to report. So some said that they'd only report if their colleague was impaired at work, making comments like a doctor who's not on call and drinks too much at a dinner party should not be reported. An orthopedist noted that the determining factor is if it impairs the practice of medicine, which makes sense to me. Another one question was, would you tell a patient if you knew they were going to have a procedure performed by a physician with substandard ability in that procedure? Very interesting question. And just over half of the respondents said that they would caution a patient against having a procedure by a physician whose abilities they question. But many doctors said that there needed to be some tact. One said subtle but clear suggestions are the best way to go rather than questioning another doctor's abilities. Many of them noted that they'd simply recommend that the patient get a second opinion, or would recommend a different doctor whose abilities they respected. More than a third said it depended on the situation, and it was it was interesting. There was even a doctor that said, a doctor practicing outside of their scope of practice, yes, I'd tell the patient, but a doctor that I think sucks, in my opinion, no. So it just depends on, you know, where they're, you know, what the situation is, but it's at least a good percentage of people said that they would tell. Okay, so I think we're on to our commercial break.
Yes, ma'am. Thank you so much. And now a quick word from symplr as it relates to this topic. As you know, symplr offers a variety of tools that can help you with things like this in documenting your provider's competency. We have a professional practice reporting module that you can run OPPE reports at any given time. You can track the provider privilege uses by an embedded ICD CPT codes if your facility is using that. It also has powerful analytics that you can customize your reports, and tracking and trending with the ability to choose some included indicators whenever you are running those. We also offer a peer review module where you can do a modern, automated, and paperless peer review process. It can standardize your process and is comprehensive in the reporting and alerts that are with it. We also have a event and incident reporting product that quickly and easily you can report incidents with any given provider. It is fully configurable to your specifications, and it has powerful notifications and analytics. You can also trigger a peer review case from any reported incident within that module. Now it's time for our Q&A portion. Again, you will be able to view a recording of this webinar along with downloading the slides later this week at symplr.com in the resource library. You will be getting an email with this link. You will be getting it from communications@symplr.com. Please make sure to add us to your address book. You also will be receiving your NAMS CEU certificate later this afternoon. I have gotten approval from NAMS, so you will be getting that today. Ms. Kathy, it looks like we've had a couple of questions come in. The first one is, should an attending physician who is supervising a first-year resident check closely after the resident does a delivery, for example?
Well, when you're in a training program, this is completely different than you know, the accreditation and regulatory standards that we've been talking about. The accreditation and regulatory standards and the documenting competency that we've been talking about during this program have been for practitioners who are out of their training program and are being, you know, out in the world now actually working on their own. So I really, I would have to defer to the program director for comments on that. I don't know how they document that there.
Fabulous. The next one is, what should be the consequences if a physician does not attend the 50% of meetings and only attends one?
That's a good question. Well, it depends on what your bylaws say. And there's a lot of controversy as to whether or not meeting attendance should be mandatory. Hospitals who do away with mandatory meeting attendance requirements soon find out that nobody comes to meetings anymore. So you have to find some other way of communicating to practitioners. I worked with a hospital that did away with their meeting attendance requirement, and they, you know, they had people that were not coming anymore, and because they had a requirement in their bylaws that people would, if you didn't attend at least half of your meetings, that you would get bumped down from active to associate staff. Well, people who were on associate staff couldn't chair meetings. Found out that, you know, there were people who were chairmen of committees that didn't attend enough meetings of their department, and if they would have, you know, if they would have bumped those people down off of active down to associate, they couldn't have chaired the committee meetings that they were chairing. So they decided to do away with the meeting attendance requirement. I think that your bylaws have to just define what that is, and it doesn't make sense to me to be a punitive thing that you would take somebody's staff status away or bump them off staff or something like that. I think we're at a point where we need to develop alternative mechanisms for getting information to people rather than through an in-person meeting. We can do, web-based meetings. We can do telephone conferences. We can do things a lot of different ways now. And I think that we need to look at ways of making it more convenient for people to participate rather than penalizing them for not coming to an actual in-person meeting.
Okay, thank you so much, ma'am. Another one is, how do you get your administration to believe that the medical staff needs to be more involved? We have a medical staff that is not that involved and an administration that likes to make decisions with OPPE and FPPE.
Well, if you look at the accreditation and regulatory requirements, that ongoing evaluation and competency evaluation is the medical staff's responsibility. Of course, the hospital is responsible, the governing board is responsible for everything that goes on in the hospital, so they are responsible for oversight of that process. I don't know how to get your administration to pay more attention to it, or to make the medical, to encourage the medical staff to get more involved. I imagine if you ended up having a lawsuit where negligent credentialing was alleged, and the medical staff, had to all go and, they're deposing your credentials committee, they're deposing your MEC, they're deposing your department chair, and those people are having to answer those tough questions about evaluations. And if they don't know anything about it, it's going to look bad. So sometimes it takes some bad event like that to get people to, to actually take notice. Sending your medical staff members to and your administrators also attending educational programs can also help, where they can hear how important that is, and know what the repercussions are of not doing the job the way that they should.
All right, fantastic. Thank you, ma'am. Ms. Janice, I see that you are having a link issue. I will send that to Kathy offline, and we will get back to you. So we will have that fixed for you in the meantime. I would like to let everyone know that you can submit your last final question that you do have if you've thought of one while Ms. Kathy was answering. Ms. Kathy, is there anything you'd like to say in closing to our audience?
No, other than if you were signing on today hoping to hear the Joint Commission credentialing and privileging standards for the medical staff, we will be covering that on May 3rd. So be sure to sign up for that May 3rd one, and we're going to drill down into a lot more detail on what the Joint Commission requires for credentialing and privileging.
Yes, ma'am. Yeah, we will be having that invite go out as well. Make sure you add communications@symplr.com, and you can keep checking online as well in our resource library for our latest upcoming webinars. Thank you all for joining us, and you will be receiving your CEU this afternoon, and you will receive the slides and the ability to watch the recorded webinar later this week. I hope everyone has a great day, and Happy New Year.
Thanks, everyone.
Goodbye.